Cancer. For some of you, this may hit close to home and may trigger some unpleasant memories, so I apologize ahead. So what do we think of when we hear the word cancer? Most of us associated with death, correct? However, it really depends on, well, what type of cancer do you have? And what is the survival rate for that type of cancer? Is it treatable? Is it curable? First, let's look at the causes of cancer. I won't dwell too much on the pathophysiology. We're not really testing that part, meaning how exactly does cancer develop. Okay, I'll just give you a general idea. First of all, we have cancer characteristics. Let's go back to the moment of conception. So Schwinger was conceived after his mom and dad, met up and said, "Sup?" And mom said, "Sup?" And then later, he was conceived. So before that, Schwinger was one cell, right? He was one egg. Then after that, after one sperm got in, he became 2, 4, 16, and so on, 64. Okay, so look at that rapid cell division. Doesn't that sound like cancer? It does. It does. So therefore, we had cancer characteristics. Okay, and we have that all this time. The only thing keeping us from developing cancer is one, that you're not exposed to a carcinogen, because if you are, then that will start the mutation process. Second, we have two sets of genes in the body. We have oncogenes, which help us grow and develop. Oncogenes, I'm talking in utero, okay, as an embryo. So we have oncogenes, and then we have suppressor genes. Okay. To simplify it, let's just call the oncogenes because it facilitates growth and development. Like in a car, that would be the gas pedal. Then the suppressor genes will be like the brake pedal, right? As long as there's a balance between oncogenes and suppressor genes, then there will be no cancer that will develop. There are two types of tumors that can grow. They can either be benign, which are non-cancerous, or malignant, cancerous. We'll compare them side by side. There will be a table shortly. Doesn't mean, even though benign is labeled non-cancerous, doesn't mean it's not going to be a cause of fatality. It can still kill depending on where did it grow. We'll get more on that shortly. Here are the side-by-side comparison, 12-1, table 12-1. So let's look at the characteristics. When we say differentiated, that means the patient has a well-differentiated function, meaning we know what it is and we know what it will do. Okay, that's what we call, and we want our cells to be differentiated. So meaning you can tell, oh, that's an eye cell, oh, that's a skin cell, that's a heart cell. Okay, when you look at it in the stethoscope. Okay, so the cells are well differentiated. It's identifiable. Oh, that looks like a breast tissue, and that's a breast cell. Oh, that's a brain cell. That's what the characteristics of benign cells are. Okay, so they resemble normal cells. Malignant cells, on the other hand, are undifferentiated. We have no idea what this cell is. Doesn't look like any normal cell. So are they easier to identify? Doesn't look like any. Yes, they're easy to identify. You get a biopsy, look at it under a microscope. Oh, it's a malignant cell. So what made them say it's a malignant cell? It doesn't look like a normal cell. Okay. So they're either anaplastic, meaning no pattern or shape or characteristics. No. Another thing is they usually have under here, it's not mentioned, but they also have what's called a larger nucleus to cytoplasm ratio. What is the nucleus of a cell? The brain, right? Right as a center. What is the cytoplasm? The rest of the cell, okay? So when you look at a normal cell, let's use an egg, for example. An egg. Is the yolk, which is the nucleus, bigger than the cytoplasm? No, it's smaller, right? Smaller than the rest of the cytoplasm. In malignant cells, the brain is so much larger. I mean, these cells have really large nuclei, okay? Meaning it gives them the ability to spread, grow really rapidly, and even invade. Okay, so the larger the brain, then the more aggressive the cell becomes. Next is the mode of growth. Benign cells has there's no growth regulation. They grow fast and rapidly. That's what distinguishes them from normal cells. They grow too fast. However, they cannot infiltrate surrounding tissues, meaning they're only limited to wherever they're growing. So let's say if this tumor is growing, I have a benign tumor in my colon. Will it bother me as much if the same tumor was growing in my skull? Which one will cause a bigger problem? The one in my skull. Even if it's benign, because what will it do? It will squeeze my brain. Okay, it will keep growing nonstop until it will squeeze my brain, cause increase intracranial pressure, cause prevent CSF from circulating. So it can kill me. However, is it likely to kill me if it's in my belly? Not likely. If it's benign, I mean, I have plenty, even now without cancer, okay, you can see the evidence there. I have plenty of space, okay? I can accommodate a tumor. I don't know if this is actually a tumor that I have, but there's space there. So it's a big difference. In the mode of growth in malignant, however, they have no contact inhibition. What does contact inhibition means? That means that if they hit a wall, they stop growing. There is contact inhibition in benign and normal cells, meaning if they hit the wall, oh, that's it. I can't grow any further. Okay, this is it. You know, just like a wave, when the wave breaks, okay, reaches the shore, and that's it, right? That's the end. Okay, that's the end of the wave. Here in malignant, there's no such thing. You hit a wall, they'll break through that wall. Make sense? So that means they can invade. So let's say you have a malignant breast tumor. Will it stay in the breast? No, it will go anywhere. It touches the lung, it will go into the lung. Okay, it reaches the highway. Let's say it takes the lymphatic circulation, it can spread. Let me go somewhere. There's too much of us here. Let's go to other places. Okay, let's go to the brain. Let's go to the bone. Let's go to the liver. Rate of growth, both again have uncontrolled, but compared to the malignant, rate of growth for benign is so much slower compared to the malignant. Malignant, get unstoppable. So because they grow so fast, so how much nutrients do they consume? So much, so that way they usually present with, causes the patient to be anemic because they rob the patient of nutrients. So they develop anemia as a result, and they lose weight because where are all the nutrients going? To that tumor. Metastasis, as already described, the benign cells are usually encapsulated, meaning there's a membrane encasing these cells, unlike malignant, wherein there is no such encapsulation. So therefore, they can invade and grow nonstop. Generally speaking, benign cells, again, as far as general effects, they're typically harmless unless again they're in a location that is tight, such as the torso, the brain. So places like that wherein the chest is confined within the ribs, right? The rib cage. So therefore, can they compress the lungs and the heart? Yes, so it really depends on where is it located. That will determine how much damage they can inflict on the patient's body. Tissue destruction, same idea. It's benign, depends. Whether it can destroy, depends really. It can, yes, it can destroy brain tissue or your lungs and your heart, as well as the inferior or superior vena cava, if depending again where are they located. Whereas malignant again, because they invade, so they will damage adjacent or even peripheral organs or parts of the body. I already described carcinogenesis. Remember oncogenes and suppressor genes? Okay. So it really depends on, are we exposed to carcinogens? Now let's name a few carcinogens. So there are ones we know. California has the longest list. Almost everything is carcinogenic in California. So we have what? What have you heard or read? Radiation, right? From the sun. That's carcinogenic. What else? What type of foods? Almost everything. Oh, well, name a few, let's say burnt stuff, right? Yeah, it's like eat, a lot of burnt, fat, for instance, you like eating that. You pretty much eat charcoal with your steak. Or yeah, some people do that. Oh, they eat like burnt stuff.
What about the powder?
The what?
Talcum powder.
Yes, so those belong under chemicals. Okay, it's been proven and lawsuits have been settled, right? Talcum powder from Johnson and Johnson. Angiogenesis is the cancer cells are able to release something called endothelial growth factor. So that's under angiogenesis, meaning if they secrete that enzyme, that protein, it will cause the body to grow new blood vessels to feed the cancer. Okay, so if I'm a tumor, I will simply secrete endothelial growth factor, and then the body will grow new blood vessels to feed me. Right? So that's how they get their nutrition. Yeah, in the endothelial growth factor. What else are considered carcinogens? Smoking, right? But tobacco. We know about viruses and bacteria. Name a few viruses. Hepatitis, right? Hepatitis can cause liver cancer. What about the adolescent HPV, right? HPV, human papillomavirus. It's been known to cause cervical and anal cancer. What else? Hepatitis. Oh, I already said hepatitis.
What else is
Which
the
type
book?
then?
About
Hmm?
one of
Which
them was
type that?
EBV. What's EBV?
B, C,
B2?
B and C.
And the EBV, the
Sorry?
EBV, right? I read that in the book. EBV, that's what it was, right? EBV. EBV.
Tell me again, what is that?
EBV.
Yeah, what is that?
She's talking about the Epstein virus.
If it's in the book, yes. Not very familiar with it, but yeah. And certain bacteria also. So when we say can cancer be prevented by vaccines?
Yes.
Yes, because we know hepatitis B causes cancer, so therefore can you prevent it? Yes, we have the HPV vaccine, right? So therefore, yes, we can prevent cancer by getting vaccinated. What about the HIV virus? Can it cause cancer? Yes, it's been linked to Kaposi sarcoma, correct? All right, so we know about organisms can cause can cause cancer. Physical agents, so we know about asbestos. correct? Mesothelioma, we see the ads on TV. There's also, I already mentioned the sun, it causes melanoma. So we have several known and even more unknown carcinogens. Okay. For chemicals, I mentioned tobacco. We don't know yet about any evidence about vaping, probably in the next decade, as soon as we get data. But since it's fairly new, right? Vaping has been around for less than 10 years so far. So unlike tobacco, it's been around for a century, so it's been proven. We don't know about others yet, particularly vaping. Table 12-2. I'm not testing it, but just be aware of the name. So as a general rule, if it ends with an OMA, it's typically benign, except melanoma, because melanoma has no benign form. Melanomas are all malignant. So if it's a, let's say, adenoma, okay, if it's an OMA, myoma, those are benign tumors. However, if they end in carcinoma or sarcoma, they typically indicate malignant types of tumors. Again, this is the exception, myeloma. Lymphomas as well. Lymphomas, well, depends which type. Non-Hodgkin's lymphomas are more aggressive compared to Hodgkin's lymphoma. For leukemia, they come in chronic and acute forms. Typically, the acute forms are deadly compared to the chronic, because leukemia can either be, since they grow in the bone marrow, they can either arise from myeloid stem cells or from lymphoid stem cells. So lymphoid stem cells are the stem cells that grow on to develop and become white blood cells. And no, typically white blood cells only, whereas myeloid stem cells become everything. They become red blood cells, platelets, white blood cells as well. But lymphoid, they go on to become white blood cells, different types of white blood cells. As far as lifestyle, so alcohol, obesity, poor diet, or inability has been linked to increasing. They don't cause cancer, but increases your risk to develop cancer. Then if you add smoking there, then increases your, plus you work around asbestos, then that increases them further. Hormones. We have data that's why we use sometimes hormones to treat cancer, meaning when we know that certain types of breast cancer or testicular cancer feed on the hormones, right? So what they do is they give them hormones that are tagged with chemo agents, meaning we give you estrogen or progesterone that have chemo in it. Okay, so therefore when those hormones are administered, what will the cancers do? Gobble them up, right? And then they die because those contain chemo agents. They contain poison. All right. In fact, before my brother, one of my brothers died, he escorted someone to, there was a cutting edge cancer treatment in Tijuana. No, just outside Texas, no, at the border. The Tijuana is a border Mexican city, right? So he was American. He did not get approval for his cancer treatment because it was too well, it was novel, but it worked. You know, he just didn't get get FDA approval because it was too dangerous. So he practiced in Tijuana. So he has a large clinic there, great setup, just like an ICU setting, advanced facilities. What he does is he treats cancer with poison glucose because what do all cancer cells eat? Glucose and oxygen, correct? So what he does is it's a ICU setting. So his patients will be treated with high doses of insulin. So what happens to the patient's blood sugar? It will drop. Okay. So again, it's an ICU setting. The patient is treated in an ICU environment. So they'll monitor his sugar constantly and then treat the patient with high dose insulin. So it will drop the blood sugar to around below 30, right? 25, 20, like that, 25. And then they'll infuse them with pretty much poison glucose that has chemo in it. So they'll infuse that, and of course, who will consume most of that glucose? Those cancer cells. So the cancer tumors will absorb and eat all that glucose. Of course, it will also kill other cells, but it will kill mostly the cancer. It's dangerous, right? Yeah, so very risky. So that's why no wonder we will never get approval in the United States. But people flock to him, especially rich people who have been given, pretty much poor prognosis by other doctors. No, they were told, we can't do anything for you. Last resort, they go to him. But he does give the disclosure that my treatment is quite dangerous. And then they still continue to sign up because pretty much they have little to no hope. Yeah. Role of the immune system. Well, the doctor my brother was the doctor, so he escorted that, basically a millionaire. He escorted him there and he survived. He lived, another 30 years. But he died eventually, of course. Somebody has to die, people have to die, but he survived that cancer.
Was the cancer completely eliminated?
Sorry?
Was it completely eliminated?
Yes, he was cured. There was some rare eye tumor. I forgot what the name, but so our immune system is part of our cancer treatment, meaning our immune system can identify, especially malignant cells, right? Because they look different. So of course, the immune system cells can kill malignant cells. Proof of that is HIV people, once they develop AIDS, what do they develop? Kaposi sarcoma, right? So therefore, they can no longer fight cancer. So they develop that type of skin cancer. All right, let's go straight to the prevention, and then I'll let you go. There are 3 levels of prevention. We have primary, secondary, and tertiary prevention. For primary prevention, that means this includes all activities. Thank you for reading the first statement, Mr. Michael.
Primary prevention involves reducing the risk of disease through health promotion and risk reduction strategies.
Very good. So what falls under here? What activities again? To reduce the risk and promote health and risk reduction strategies. Let's compare it to secondary. What does secondary say, Miss Peguero? Okay. So what again? These are screening, right? Screening and early detection. In which people? People who lack signs and symptoms of cancer. It's important to distinguish here because some of you might not agree with the recommendations, because for this purpose, we will go to the American Cancer Society website. because they are the man, they're the experts in cancer. So we will use them as a resource for these questions. Tertiary, on the other hand, is what? What does tertiary involve? Thank you, Miss Stevens.
Wait,
Right here. Tertiary prevention efforts focus on
monitoring for and preventing recurrence of the primary cancer as well as screening for malignant in cancer.
malignancy. Okay. So let's summarize. Primary was, what was it? No, primary. Avoidance of, okay, reducing the risk and health promotion, right? Okay, and then risk reduction. What was secondary? Screening, early detection in who? In people with no symptoms of cancer. Okay. 3, tertiary. In cancer survivors, meaning you had cancer, you survived it. We're just monitoring you for either the recurrence or some new cancers.
Also treating it too, right?
No, this is just simply prevention. All right. Are we clear? All right. So we'll do management next week. So let's finish these 3. So what falls under here? What activities? So everything mentioned in the paragraphs. So therefore, what activities fall under primary prevention? So if I give you a next gen question asking you to categorize, so where would you put these activities? Let's say I put there immunization. Where will you put immunization? Primary. So you'll drag them under primary. Again, let's repeat. Primary is risk reduction, okay? Reducing risk and health promotion, meaning eating healthy, etc. Secondary is what? Screening, early detection in who? In people with no signs and symptoms of cancer. Tertiary, cancer survivors. So these are now monitoring the people who survived, meaning, successfully treated cancer. We'll monitor them. Did it return or did you develop new ones? Because what is one of the causes again? Radiation, correct? One of the treatments for cancer is radiation. So can that treatment cause a new cancer? Yes, this time resulting from treating another cancer. And then unfortunately, it caused a different type of cancer, right? So let's go to secondary. Now for secondary, this may not be accurate anymore because this textbook was published when? 20, something like that. Okay, so we have to go to cancer.org. So type in cancer.org. I'll show you how to navigate and find the early detection because the dashboard here, the main page changes constantly. They keep changing. It's not the same picture. It's not the same setup. So scroll down to get screened. Okay. So cancer.org, scroll down to get screened. Then the next page, we'll look at scroll down again and we'll look at, like I said, it's never the same. Okay, so right here, the first tab is cancer screening recommendations. So stay there. And here we are. So the 3, we'll only do the first 3 because I can't find the statistics by year. They publish the statistics every year. They show you cancer cases by cancer type and by gender, and then cancer mortality side by side. So for female and male, the top one is incidence is breast cancer. And then for males is prostate cancer. However, and then the second is, I believe, lung and bronchial cancer. And then the third is colorectal cancer. For mortality, however, the number one killer is colorectal. No, sorry, is lung cancer. Lung and bronchial cancer was number one. Number two was colorectal. And then third are breast and prostate, respectively. So it's not really the same. So yes, high incidence for breast and prostate. However, they're number three for mortality. What does that tell you? So in America, all 50 states, the incidence is highest incidence is breast for female, number one for males, prostate. But mortality, both are number three. What does that tell you? They are treatable. Okay, meaning, is our treatment working?
Yeah.
And more importantly, is it really the treatment or the detection? The detection. So therefore, will we continue to promote these American Cancer Society initiatives? You know, that we have the breast cancer walk, you know, the breast cancer awareness month. So do we continue these? Yes, because it's working. It's making people more aware, you know, about breast self-examination, when and how to do it, you know, how often. Okay. So we continue the initiatives. So anyway, let's look at the screening. So we'll only do the three. We won't bother with the lung because the only recommendation for detecting lung and bronchial cancer, especially if it's a smoker, is a CAT scan. That's it. There's really nothing to know. Okay, so what's the screening? Well, get a CAT scan. That's it. Here, there's a few guidelines. Okay, so for 25, let's go to the here, cancer screening by age. Okay, so let's start with 21 to 29. Do we need colorectal cancer screening? Well, depends. Let's say, look at here. If you are higher than average, that means you have cancer, colorectal cancer in your family. So are you average or higher than average? That's higher than average. Then yes, you go get plus the colorectal screening is not a colonoscopy anymore. It's now a Cologuard, you know, stool-based exam. You just submit a piece of crap and then they'll test it for cancer. Okay, so it's more convenient. Would you like a colonoscopy or just a stool specimen? That's easy. Yeah, I'll do that. Yeah, here you go. Because I've had 2 colonoscopies in my life. It was a hassle. I have to prep. I have to get anesthesia. I can't drive home. It's very uncomfortable. Okay, you can feel whatever they're doing. Okay, it's embarrassing. So I'll take the stool specimen. Okay, here, I have a big one. Okay, here's a big piece. Check all that. Okay, maybe you'll find more. Eat the rest. Okay. If not, see, meaning your average cancer risk, not needed at this time, 21 to 29. Breast cancer. Says here, if you're 21 to 29, is it needed? Again, unless you are higher than average. So no, not needed at this time. Cervical cancer screening, still no. It says you start at 25. So these things change. Okay, let me give you an example. In 2008, when I first started teaching, so I was required to look at this because I was teaching nursing. The recommendation was all sexually active women, meaning if you have an 11-year-old who was sexually active, they were screened for cervical cancer. They had to do a pap smear. All right, so that's changed. Again, the recommendations changed because why did the ACS change it? Data. Okay, they base it on data. What is the data saying? So they make recommendations based on evidence. So evidence says it's very few cervical cancer at this age. So no, stop that. Okay, So now they started at 25. So 25 to 65, you'll have a HPV or a pap smear. How often? Every 5 years. All right. So let's go now to 30 to 39. So what's the recommendation? Again, we're only doing 3: colon, breast, and cervical. So colon,
Only to 5.
no. So still no. 30 to 39, too young. Unless again you are higher than average. What about breast? 30 to 39, not needed at this time. No. If you're average, okay, higher than average, of course, yeah, go get mammo. Cervical, yes, now, yeah, because it starts at 25. It's 25 to 65, right? So it continues from 30 to 39. Let's go to 40 to 49. Who gets it now?
Everybody.
Okay, so you need, for females, you need a pap smear, and then for both genders, do they need colorectal?
Yes.
Yes, it starts at what age?
40. And then 40 and to 49.
Well, let's look at the recommendation. So let's start here, 40 to 49, colorectal. Do we start? Yes, at 45. In 2016, I saw the big posters. It said 50. Now they went 45. Why do you think they started earlier now? Again, data changed. So more and more people at 45 were developing colorectal cancer. Again, what is it exactly? So it doesn't say sigmoidoscopy or colonoscopy anymore, which is good. So it encourages more people to submit stools, okay, stool-based exams. Okay, let's check you out for cancer. Breast, 40 to 44. What is the statement? Should have the choice. So do they have to? No. 40 to 4, what is this? 40 to 49. 40 to 44. Yeah, if you want. Yeah. Will the insurance cover it? Yes, because it's recommended here. 40 to 44. A woman has a choice. However, at 45, what's the statement now? You should. Okay, you're 45 years old. You should get a mammo. All right. Cervical cancer. Yes, you continue. 25 to 65. Then finally, let's look at the last year, 50 to 64. You guys should be on the website too, following with me. So for colorectal, 50 to 64, yes, because we started at 45, right? So you're still within that. Yeah, go ahead, get the stool-based exam. Lung cancer, again, it's only a scan anyway. Okay, so 50 to 80, yeah, get a CAT scan. Breast cancer, continue every year. 50 to 54, continue every year. There's a few things here. Let's say at 55, you switch to every 2 years now, every other year. No more annual. Okay, so less frequency. What about cervical? Continue. And finally, if you're old, above 65 now, 65 or older, what's the recommendation? Start with colorectal. Yeah, you test until 75. Lung cancer, yeah, continue, CAT scan. Breast cancer.
2 years.
Okay, so now you're now over, this is now 65, right? So every 2 years, or get one every year. That means insurance is obligated to pay. Now let's go to cervix. There's a few things here. No testing. If you've had regular cervical cancer testing with normal results in the last 10 years, then there's no point. Okay, you're 65 and older, you've been testing. No more. Okay, you've been testing, you've been clear. If the patient had hysterectomy, meaning there's no cervix, right? They had a hysterectomy. Only if the hysterectomy was unrelated to cancer. let's say you had hysterectomy because you had, I don't know, a tear in your uterus. You had too many C-sections. Okay, so we lost it. Or let's say you have fibroids. Okay, or let's say endometriosis, something like that, non-cancerous reasons. Then no more testing. I mean, what's there to test? You have no cervix anyway. However, if they did lose the uterus for cancer, then they continue testing. Prostate, it's only a PSA anyway. It's a blood test, so it's nothing really invasive. That's it for today. So quiz next week.